Shall I start? Good morning. My topic is effect of online education on refractive status of school children after COVID-19 home quarantine. We all know that too much of near work and less outdoor activities actually predisposes kids to higher amount of myopia. But during the pandemic, the e-learning was the only option that was available for our school-going kids. And should I start again? Please put the timer, no? Ah, okay. So I'll be talking on effect of online education on refractive status of school children after COVID-19 home quarantine. We all know that too much of near work and less outdoor activities predisposes kids to higher amount of myopia. But during the pandemic, e-learning was the only option that was available for our school-going kids. Desk One study has reported that there was a remarkable increase in digital device use from 1.9 hours to 3.9 hours. With this background in mind, we started to investigate the effect of online classes on refractive status of children after COVID-19 home quarantine. Our methodology was a questionnaire-based cross-sectional study. Google Forms were posted in WhatsApp groups of classes 1 to 10. The parents were asked to take the survey between August to September 2021, during which time e-learning was going on. The questionnaire consisted of 3 parts: demography, part 2, use and awareness of digital device, and part 3, about the use of glasses. Statistical analysis was done using Microsoft Access and SPSS software. Our results show 376 parents took the survey, and out of them 72% respondents were parents of classes 6 to 10. And the chart below is showing all the data that we retrieved from our survey. Boy-girl ratio was 54% versus 45%. 43% kids belonged to the age group 10 to 14 years. And what was relatively different from the previous studies were that in our case, 87% of the kids were using mobile phone for attending online classes. When we inquired about the hours of usage, 59.4% patients were using mobile phone for 4 to 6 hours. When we consider the refractive status in the junior classes 1 to 5, pre-COVID glass users were 2.9%, which increased to 6% post-COVID. In classes 6 to 10, 7.6% glass users increased to 12.3%, and both these are statistically significant. When we inquired about the awareness of parents about digital eye strain, they told that 43% of the kids were experiencing digital eye strain. 53% parents were aware of digital eye strain, but surprisingly, only 25% of the parents were actually doing device restriction on the kids. What we already know from the previous studies is that myopia is increased, digital eye strain is increased on too much of visual display terminal use. What our study adds is 53% parents are aware of harmful effect of digital device. 57.4% parents actually do not restrict their kids from too much use of digital device. Another 56% parents have never read about digital eye strain. We have certain limitations since this was a questionnaire-based study, so there can be possibility of recall bias. So we strongly recommend that digital eye strain should be included in the curriculum of classes 3 to 5, especially in the environmental studies book or in the social science subject. Screen use, do's and don'ts should be taught in school for primary section so that it can give rise to a parent's awareness. Thus, we conclude that parents of school children are largely ignorant of digital device use, so print media and textbook can play a key role in bridging the gap. Thank you very much.
Okay, doctor, good study. This questionnaire has been sent to the parents or to the children?
The survey was taken up by the parents. The parents have answered the Google Forms.
Then how parents will assess the myopia, or what is the power, or how they?
The glass use was asked whether their kids already were using glasses prior to the myopia, or then whether before now, when the survey was done in 2021, whether now your kids are wearing glasses or not. And if they are wearing, what power of glasses are your kids wearing?
Okay, good.
And one more thing I wanted to ask you was, you said that about 53% of parents were not restricting their children from device use, from screen time.
Correct.
So, did you do anything about that? I mean, did you advise the parents regarding that in your study?
Yes, in our survey only, at the end of the survey, we had given a directions or recommendations for mobile use in that Google form itself, so that parents can just at least go through it and know little bit about how not to tell too much kids should not be using digital device. That is the only thing we did actually.
Yes, but I know we all say that they should not be using, but the fact of the matter is that parents themselves very often hand over mobiles to children just to keep them busy, so that they are not disturbed.
So that we parents can do our own works and let the kids be.
Exactly, because we all see it in our own homes, I think.
Yes.
So I think this is a very relevant poster. It carries a lot of meaning, especially now, post-COVID.
That's
so.
What,
thank you, Hemanti. Any other questions?
Thank you, ma'am.
Next speaker, Dr. Prerna Shetty. Is she there?
Is she there? If not, call the next one.
Nida Khan. Sudank Bhadara, is he here? Sudank? Shushank Valirao? No. Here, there? Okay.
Okay, please come. Take off all of us. I want them also with me. Please start.
उधर क्या?
After the session, we'll all
Yes,
presenters,
of course.
even presenters also.
बिल्कुल. Sushant, the fourth one. The fourth one. Sushant. It's come well. Very nice. Thank you. Please start and
Good
please
morning.
finish in time.
Good morning everyone. I would like to thank all organizers for giving me this opportunity, and I will be presenting a poster on fenestrated scleral contact lens, improving visual outcomes in post-penetrating keratoplasty eye. So main goal of penetrating keratoplasty is visual rehabilitation, but it frequently causes abnormality of refraction like high degrees of astigmatism, irregularity, or anisometropia, which prevents the achievement of satisfactory vision and create a primary optical challenge. Rigid gas permeable contact lenses may not be always appropriate, and variable curvatures both centrally and at the donor host junction are often the reason for rigid gas decentration or even complete ejection from the cornea. So scleral contact lens can cause acute corneal edema after prolonged use in post-penetrating keratoplasty eyes, and various ways to reduce the corneal edema has been discussed in various studies. Fenestrated scleral contact lens reduces the corneal edema and improved the visual acuity significantly in post-penetrating keratoplasty eyes. And this was the first case which showed the reduction in corneal edema with fenestrated scleral lens in post-transplanted eyes. So purpose was to report a case of fenestrated scleral contact lens reducing the corneal edema after 4 hours of use and improving visual outcome in post-penetrating keratoplasty eye. So it was a 19-year female which had infectious keratitis and treated, then which was healed and later treated with penetrating keratoplasty in left eye, and would later develop cataract, for which phacoemulsification with foldable intraocular lens was done after 2 years. So RGP trial was done and the patient was symptomatic. So scleral lens improved her visual acuity from 2080 to 2020, but after 4 hours of scleral lens uses, there was a significant corneal edema, more than 30 microns change, and visual acuity was dropped to 20/40. So to reduce corneal edema, vault, that is distance between scleral lens and cornea, and material of the lens changed while ordering the lens, but corneal edema still noted after 4 hours of lens uses. So fenestrations was made on the lens to allow more oxygen transmission, and interestingly, after 4 hours of lens use, the corneal edema reduced to 9 microns and visual acuity improved to 20/20. So scleral lenses predate all other types of contact lenses, and for a long time they were the only contact lenses available, and hypoxia was the primary concern while fitting the lens. The advancement of gas permeable materials and development of computer assisted manufacturing technology have led to gain worldwide popularity of scleral lenses, decreasing the complications related to hypoxia. So corneal squalling may be a response to hypoxic stress, increase intraocular pressure, functional condition of the endothelium, lens suction, and variation of osmolarity. So gas permeable fenestrated scleral lenses may potentially reduce the corneal edema, microcyst, midday fogging, lens suction and lens instability, conjunctival compression, and alteration of intraocular pressure. So a FENES conclusions are a fenestrated scleral lens reduce the corneal edema by allowing a pathway for freshly oxygenated tears, tear exchange and dispersion of carbon dioxide from behind the lens, break the lens suction and release the tension from eyelids on ocular surface, and maintains normal osmolarity. And it can be used in cases of acute corneal edema, especially in post-penetrating keratoplasty eyes. So although it was a first case report, but further studies with larger number of cases is needed to show the more conclusive data.
Okay, doctor, good idea. Who is making the fenestration? The company people, or you are making?
No, company people are making.
Ordering, you are giving instruction and they are making.
Yes, they are making in the superiotemporal, near the superiotemporal limbus, and they are giving us at free of cost for all patients.
So customized.
Yes, they are customizing.
Which company is this?
This is Boston side scleral contact lenses. They are giving us the lens.
But you have done this only in one case?
No, by the time of abstract submission, it was only one case. Now it is 13 cases and all results are good. So we are going to publish this.
You can present the 13 cases next time. Next time. But it's a good idea, I think. Because
and it is accepted in one of the journal also. So it will be published in 3 months.
Very good. Excellent. Thank you.
Thank you. Thank you. Good day.
Presenter is Dr. Nida Khan. Is she available? Yes. Lakshmi KS. Doesn't look like. Next one is Dr. Pritika. Dr. Pritika is there. Yeah.
Excuse me, let me tell you that since you are not a ratified member yet, so we are not going to be marking your presentation. You are allowed to present, but you are not competing. Okay, thank you.
Good morning to one and all present here. So my topic is on the significance of monoocular pupillary distance in prescribing glasses. So monoocular pupillary distance is the distance between the centers of each pupil to the bridge of the nose, whereas interpupillary distance is the distance between the center of both the pupils. So accurate measurement of MPD ensures proper centration of glasses, which improves visual clarity and reduces eye strain. MPD becomes necessary when a person's eyes are not equally proportioned, wherein one pupil could be a few millimeters away in comparison to the other pupil in the other half. So the nose or the glabella may or may not be centered relative to the sides of the head, and the eyes may or may not be equidistant from the center of the glabella. So whether we term them as monoocular PDs or half PDs, there are refinement in data gathering that can help supply better performing eyewear to patients. Monoocular PDs are important for designing high performance prescription eyewear. So the aim of this study is to measure the monoocular pupillary distance and interpupillary distance in patients with refractive errors to analyze its significance while prescribing spectacles. So my study design was a cross-sectional randomized study with a sample size of 500 patients done over a duration of 6 months at an ophthalmology department in a multi-specialty hospital. The monoocular pupillary distance and the interpupillary distance was measured using a pupillometer and evaluated in each patient, and patients who were prescribed glasses with refractive errors were included for this study, whereas patients having other ocular or neurological conditions other than refractive errors were excluded. Monoocular pupillary distance and interpupillary distance was measured in 500 patients. Of the 500 patients, 250 were males and 250 were female glass wearers. Out of the 250, 215 males had the same MPD as IPD, whereas for 35 of them it varied, and out of the 250 female patients examined, 210 had the same MPD as IPD, and it varied in 40 females. This approximately accounts for 15%, the variation that is, of the total population taken into consideration, and an average of 1 millimeter was seen in any one eye, thereby causing a significant change. To conclude, both the parameters are crucial while prescribing glasses to avoid decentration, discomfort, patient dissatisfaction, and other asthenopic symptoms. This study, though a small sample size, helps in creating an awareness among ophthalmologists and optometrists. Thank you.
Okay, doctor, good study. You are using a pupillometer.
Yes, sir.
So can you, in simple words, can you explain with the pupillometer how we are measuring the MPD? So in the IPD you can measure with the pupillometer. So the MPD, how we are measuring with this pupillometer?
So MPD, preferably we measure after, with the centration with the lens, after, while the frame fitting. So from the center of the frame to the center of the glass lens, we have to measure and give them, sir, the glasses.
No, but see, you yourself said in your presentation that the center of the nose or the glabella may be different in patients. So how do you decide what you are taking as the center? Because monoocular pupillary distance is from the center of the pupil to the center of the nose, isn't it? So in your own statement, you have said that it can differ. So how did you decide what is the center of the nose?
Center of the nose.
We took the glabella point only, ma'am, and we measured, asking the patient to look in the straight gaze, we measured to the center of the pupil.
Okay. That's okay. But how did you decide what is the center of the glabella?
That's a subjective finding, correct?
Yeah.
What point you take, I may take some different point.
See, you are deciding that this particular point is the center of the.
Yes.
I may not feel it is the center. For me, it might be a little different. But yes, your study is very valid, because I agree that this makes a lot of sense. Measuring the monoocular pupillary distance, we often, as ophthalmologists, do not bother about how spectacles are being prescribed. Means we don't tell the patients anything about how they should go and buy the spectacles. We leave that to the optician, not even to the optometrist. We leave it to the optician, who can mislead them in a number of ways, especially when it comes to specialty lenses like progressives, and other lenses, glasses of those kind. And another thing I'll tell you, you're very right that monoocular pupillary distance will vary in the two eyes, because I have myself noticed that the height of the two eyes is never the same.
Yes.
When you put the patient on the slit lamp and you go from the right eye to the left eye, invariably I have to either lower or raise the chin rest.
Correct.
Which means that the two eyes are not located on the same plane
Same level.
in the patient's body. So
yes.
this I noted many times. In fact, I had thought of doing a paper on it also. But after your presentation, I think I will now.
Oh.
But very good presentation.
Thank you.
Good idea. But take it further, and your sample size is not small. You have 500 patients.
Yes, ma'am, we get a lot of refractive error cases.
So don't call it a small sample size. See, don't run yourself down. People present 1 and 2, so it's okay.
Okay.
Thank you. Next up.
Dr. Angu Tinna. Yes,
Next page, sir. Three more. Next page.
Angu Tinna, okay.
Not there? Okay, next one, Dr.
Damaris.
Magdalene. Please come.
Anisometropia.
Yes, she will be talking on correlation of anisometropia with axial length and corneal curvature cross-sectional study.
Good morning. I will be talking to you about correlation of anisometropia with axial length and corneal curvature in institution-based cross-sectional study. Anisometropia, as we all know, is defined as a difference of one diopter in the spherical equivalent refraction with an incidence of 4 to 35%, and above 40 years is about 18%. The factors causing anisometropia in children include corneal curvature, anterior chamber depth, lens status, vitreous cavity length, and axial length. The aim of our study was to determine the relationship of axial length and corneal curvature in anisometropes ages 6 to 16 attending the pediatric OPD department of a tertiary eye care hospital. This was a prospective hospital-based observational study. 100 subjects aged 6 to 16 diagnosed with more than one diopter of anisometropia. We took only myopia. Exclusion criteria was other ocular pathology, history of ocular surgery, trauma, and manifest squint. Subject evaluation included informed consent from the parents of all participants as per ICMR ethical guidelines, comprehensive ophthalmological examination, and measurement of axial length using IOL master, and measurement of corneal curvature using the manual keratometer. Among the 100 subjects used in the study, the mean standard deviation of the spherical equivalent was 3.52 plus minus 2.08 diopters, all the subjects being myopic and isometropic in nature. And the axial length difference was 1.59, the mean K difference was 0.15, and the axial length by corneal curvature difference was 0.25. A positive correlation was found between the spherical equivalent and the axial length difference between the eyes, with a radius of coefficient is 0.61 and statistically significant p-value, and also a positive correlation was found between the spherical equivalent and the axial length by corneal curvature ratio between the eyes, and it was statistically significant. Our study indicates a moderate positive correlation between anisometropia and axial length, which is in line with Canal and Kendall's assessment of ocular parameters in anisometropic amblyophias, that is myopic eyes having longer axial length and hyperopic eyes having shorter axial length. A positive correlation between anisometropia and axial length corneal ratio. That is, when the axial length increases, there is a corneal compensating factor. That is, the corneal curvature becomes flattened and it maintains binocular equilibrium. This is the best indicator for emmetropization, could be used to monitor anisometropia and its progression. But there was no correlation between anisometropia and corneal refractive power. However, in high anisometropic patients, there was no difference between the corneal curvature between the two eyes. We established a moderate correlation with changes between the eye difference in axial length and the changes between the eye difference in spherical equivalent refraction, similar to the study by Tong et al. Thus, in conclusion, axial length is an important component in dioptric difference in an isometropic eyes, with no significant correlation between the corneal curvature and the dioptric power. The results suggest that axial length by CR ratio is the best indicator for ametropization and could be assessed as an observational indicator to monitor anisometropia and its progression due to the effect it has on refractive errors. A value of AL by CR ratio above 3 could be considered as a risk factor for the development of myopia in ametropic eyes. Thank you.
Okay, doctor, good study. But in the definition, you said anisometropy is difference of more than one diopter, but the textbook says more than 2 or 2.5 diopter usually.
We have taken a difference of 1 diopter between
for
the
this
two
study.
eyes. Yes, for the.
And now after the study, you think axial length is more important than the corneal curvature?
Yes, axial length plays an important role.
But the usual theory is the myopia is caused mainly by the change the curvature of the cornea.
Yeah, that is what happens in ametropization. So if there is an increase in axial length, how does the eye compensate? There is a corresponding flattening of the corneal curvature, and the patient maintains ametropization. When he fails to maintain that, the person develops myopia. Okay, and in the biometry, when we do a biometry, the axial length, when you can do for all patients, you can tell the prognosis of myopia also. Axial length by the average of the corneal curvature, if it is more than 3, invariably you can tell them you are going to progress, the myopia is going to progress. This is again an indicator for axial length.
Did you compare the patients with hypermetropia, or in this particular study you have taken myopia only? Any particular reason?
I did only myopia.
But you wrote in that, I think, I thought you included hyperopes also.
No.
I was only myopia.
Specific.
Okay,
yes.
Perfect. It's a very good study, I think. And
it is okay, but
and has a clinical implication. It has a clinical implication,
yes,
which is the important thing.
And it also has a prognostic factor for telling the patient your myopia is going to progress.
Exactly.
Any patient for that matter.
Exactly.
It is very practically, I've seen it in my prior practice.
Absolutely, absolutely. Yes. Thank you so much.
Thank you so much.
Last. Dr. Astha Agarwal, next presenter.
or anybody
She's there. Are you there? Is your presentation loaded? Then come. We are going to follow the activities names once again.
This. Myopia induction.
Good morning, everybody, respected judges on the podium. So my topic is myopia induction by chlorthalidone. I have a case series. Okay, ma'am. I have a case series, myopia induction by chlorthalidone. I have 3 cases to present. So in the introduction, I would like to say that transient drug-induced myopia is a very known entity, and a lot of drugs have been attributed. In this particular case series, I would like to present chlorthalidone, which is a very common systemic hypertensive, antihypertensive drug. In the first case, a 25-year-old male patient came to us with sudden diminution of vision with a history of 1-day diminution of vision. And he had recent onset hypertension. On poking and prodding, he gave definite history that diminution of vision started 4 hours after the intake of first dose of tablet chlorthalidone 20, and his previous refraction with us only had showed emmetropia. On ocular examination, just the uncorrected visual acuity was less with subjective correction of high myopia, that is -4 or -4.5, rest of the examination being normal. Provisionally, we came to a diagnosis that it's chlorthalidone-induced acute myopia, and we just stopped the tablet chlorthalidone and prescribed 2% homatropin twice a day for 1 week to counteract the ciliary spasm. And then refraction after 2 weeks came back to 6/6, uncorrected visual acuity. Second case, it's a 45-year-old male patient who came with sudden diminution of vision since 1 week. Glasses prescribed by an optician over the counter 1 month back, and he said with his glasses now he can't see. He is a known hypertensive. Again, on poking and prodding, we found that the patient was on tab Amlovas, which he had changed 3 weeks back coincidentally. And visual acuity with glasses was 660, but uncorrected was 6.6, with previous glass prescription being -5 and -6. Rest of the examination was normal. So provisionally we came to a diagnosis that this probably was a chlorthalidone-induced acute myopia, which has reversed on withdrawal of the drug coincidentally. And we advised discontinuing the use of glasses, and we created some awareness with the patient as to how chlorthalidone affects his eyes and their physician as well. The third case was a 64-year-old male patient. He came with sudden painful diminution of vision since 1 day, which is associated with headache. He has had both eye cataract surgeries, and he's a known hypertensive since 5 years on tab Amlovas. Uncorrected visual acuity was 660 in both eyes. Subjective correction, here you will notice that even though there is high myopia, the improvement, subjective correction, even with that, it didn't improve beyond 624 in the right eye and 618 in the left eye. There was central corneal haziness, shallow AC, pseudophakic, and choroidal detachment was seen, which was confirmed on B scan, and gonioscopy showed closed angles and IOP was high. So provisionally here we came to the diagnosis that chlorthalidone-induced acute angle closure with choroidal detachment and acute myopia. We stopped chlorthalidone. Here we had to give oral steroids with antacids, short-term oral and topical anti-glaucoma medication. We didn't find the need to give YAC-PI because after 2 months with just this therapy, best corrected visual acuity came back to 6/6, ocular examination being very unremarkable. So based on these 3 cases, coming to the discussion part, ocular effect of the drug chlorthalidone included transient acute myopia, acute angle closure glaucoma, and choroidal detachment. Mechanism, we would like to attribute it to allergic reaction to the drug, ciliary spasm, ciliary body edema. Unlike other commonly known drug, topiramate, there is no role of lens hydration here because it happens in pseudophakics as well. If the drug is continued, it leads to irreversible sight loss. I would like to conclude by saying awareness is the key to diagnosing this. So unless the eye knows this, the brain can't diagnose it. It's prudent to do ASOCT or gonioscopy and V-scan to rule out the more hazardous effects of this drug. And drug withdrawal with supportive treatment and cycloplegia and glaucoma for a short duration is the treatment for this. Thank you for listening to the presentation.
Thank you, Lakshmi. It's a good study.
Thank you, sir.
How will you suspect that the drug is causing this problem, chlorthalidone?
So that is the only thing that was there in these patients. In acute myopia, there has to be some predisposing factor. They had no other drug history. That is why these 3 patients and this chlorthalidone in the physician, where we sent for our physician fitness, generally, he was used to prescribing Amlovas, which is a very common drug for him. That is why we found many cases. Otherwise, not many physicians prefer chlorthalidone, but some do prefer it, and in them, this is more common.
Why you suspected this? In the literature, is any mention?
Yes, sir. Yes, sir. In IJO in 2001, there is a study with 1 case where they've told that there is acute myopia. That is why, because when I started to research what could have caused acute myopia in them, this was the cause that I found.
Okay, then it is okay.
But in one of your patients which you mentioned, the patient was already on these 2 drugs, Amlovas and
he was on Amlovas, ma'am. They had stopped Amlovas. It so happened that they had changed it to metoprolol because his BP was not coming under control with Amlovas. So they changed it to metoprolol.
No, I'm not talking of that patient. The third case, I think.
Third case, yes, ma'am.
He was on the drug for a long
5
time.
years.
So then, why did he suddenly develop?
That can happen is something that I would like to point out. The ranges vary, and it can happen from a very short duration to later on. Something triggers it, what we don't know.
Means it could be a cumulative effect, maybe.
It could be, ma'am.
Okay, because that point I was noting.
Yes, ma'am.
That this patient has already been on the drug for a long time.
Yes.
And then why did he suddenly develop?
Yes, ma'am. He was on it for 5 whole years before he developed.
So that means the in effect the take-home message from your presentation is that physicians need to be sensitized.
Yes, ma'am.
To this
Physicians
issue,
need to be sensitized.
because they are the ones who are prescribing for
yes,
hypertension.
that is true.
We are only seeing the after effects.
Yes, ma'am.
Yeah, I think another take-home message is all the clinicians, while doing their practice, be aware of the systemic medicines patients are taking. We should be very observant and ask the patient what are the other medicines he is taking for the systemic diseases. And many times it may happen due to side effect of the medicine. The patient may have complaints. This is a very, very important point.
Yes.
Thank you.
Thank you, sir.
After withdrawal, how early the myopia reversed?
When there was just myopia and nothing else, 2 weeks. In both the cases, we found 2 weeks was more than enough, and it came back. But emetropia came back. But in this patient who had choroidals, we continued the steroids. It took about 2 months for it to become 6/6, sir.
Okay. Humide was also continued for 2 weeks.
Yeah, ciliary spasm was there in them. They say, the studies say that ciliary body hydration can happen. Smooth muscle can get edematous. That is in the sheet, the long sheet chlorthalidone side effects. They tell smooth muscle edema.
Okay.
So ciliary body edema is something that we can associate with it.
Yeah, right. I get it.
Thank you, ma'am. Thank you, sir.
Next person, Dr. Pranish.
Panish Devi.
Is present. Yes. Please start. And please, everybody stick to time. Don't exceed the time.
I'd like to thank the judges for the opportunity. So today my post-op podium presentation is on refractive outcome comparing to, little more closer, okay. My presentation is on comparing refractive outcomes of two posterior chamber phakic intraocular lenses for correction of keratoconus having centered and decentered or paracentral cones, which is a comparative analysis. And this is the first study which is comparing the efficacy in the central and paracentral cones. So aim was to compare the clinical efficacy. We used Visian implantable with a central flow and used IPCL as a second lens to compare and their efficacy, refractive efficacy in keratoconus. And we had 126 eyes in our study, and we also had 12 case post intacs. So our thought process was that the ICL and IPCL doing a refractive correction, these people have myopia and astigmatism too, so we thought that whatever they're going to get in spectacles, they're definitely going to get with this. And it being closer to the macula, their refractive outcome is definitely hands down going to be better, because a spectacle will always be pronounced to aberrations because of ill-fitting or movement. So inclusion was stable refraction, age, endothelial cell count of more than 2,500 cells per millimeter square, anterior chamber depth of 6.9, 2.8 or above, BCVA of 6.9, and we had a minimum follow-up period of 1 year. Most of the parameters were calculated within this study period, and any other cataract deviators or glaucoma patients were excluded. So we used pentacam. We did white-to-white measurement with lens star and counter-checked with digital calipers. And we used check endothelial count with Topcon SP1, and then used a modified vertex formula. Surgical for procedure was a single surgeon doing the procedure, and toric lenses also were implanted, and statistical analysis was done using ANOVA, and the values were Bonferry corrected, just to give equal weightage to both the centered and decentered cones. So this was the pre-topographical data, where you can see the corrected distal acuity of 0.6 plus or minus 0.13, and these patients had a cylinder or astigmatism of minus 3.58 and 1.61. So usually people who are having more toricity on the higher side, they'll be more moving towards IPCL implantation, because ICL doesn't expand itself for patients who have a higher cylinder. And the AC depth also was normal. So IPCL, AC depth also was normal for most of the cases. So this was the comparison between the two groups at different periods of time, and we found out that when taking the pre-op visit and the post-op visit, the corrected distant visual acuity correction there was not much of a change. The values were significant, and also the mean difference with the refractive parameters also were under statistically significant because they had a good p-value comparison. So this was the division between the central and the paracentral cones or decentered cones, where 50% of the cone, if it's outside the central 3 mm, we took them as paracentral. And at the final follow-up, we wanted to compare to see the performance within the central and decentered cones, and we found that both are more or less equal, because usually people don't implant these phakic lenses for decentered cones. But this study will definitely encourage people to progress towards that direction. And this was the efficacy index of the study, where the post-op uncorrected and the pre-op corrected distant visual acuity was taken into account. We can see maximum amount of the candidates had a good corrected visual acuity, and also we had a accuracy target of close to plus or minus 0.13 diopters.
Please wind up, finish.
Yes, ma'am. I'll just conclude, ma'am. So this is the first study to analyze the refractive outcomes of using these lenses in central paracentral cones, and they have a very good safety and efficacy index, and it's very much comparable to other studies. So this study would like to consider that implanting ICL IPCL for central and decentered keratoconus can be carried out more frequently. Thank you for your valuable time. Thank you.
Okay, doctor. After the study, you said ICL and IPCL both are equally good, or
sir?
Which one is better after your study, or both are good?
Both are good, sir. As far as the material and as far as the outcome that you get, both are good. The IPCL one advantage is cheaper.
Advantage?
It's cheaper.
Oh, cheaper.
Because ICL you import from Switzerland, so import duty carries on to the price.
Yes. What is the difference of price? How much?
Almost 30,000.
Difference?
30,000 to 50,000 difference will be there.
Okay, good.
And also, when you have an ICL, you have to order, and to procure it, it takes time. IPCL, it's not the same case.
So there is a difference of price of 30 to 50,000?
50,000, yeah. IPCL is Indian, it's much cheaper.
Okay, good.
And if you use Pentacam HR, you get excellent.
Sir, I'm not, pardon me, sir, can you please?
Pentacam HR.
Pentacam HR, yes, sir.
The results, equally comparable.
Sir, white to white, we usually do it twice, sir, because once you have a sizing issue with these lenses, then, these lenses, these patients are like LASIK patients. They're always, one stop, and then you cannot tell them that, okay, chalo, again we'll dial or we'll replace the lens. And also, explanting an ICL or IPCL lens it's really difficult. You see videos where they say that we don't have lens touch and all, but most of the instances, most of the times you can have a lens touch, and that area will become cataractus. So, sir?
Thank you.
Thank you.
Thank you.
Do we have any of the other presenters available? I'll just call out the names quickly once. Dr. Ankush Bhosle, then Dr. Nida Khan, Dr. Ankur Chinna. No? So then we wind up, and I would request all the presenters to please wait. We are going to take a picture with all of you, just memory's sake.